Pradeep Pendyala, Professor of Anesthesiology. Today I am going to talk very briefly about fluids and electrolytes requirements in children pediatric age patients. I'm sure you know a little bit. I'll add few more information, believing that it might be helpful to you. A little information about fluid and electrolytes for pediatric patients. See, physiologically composed balanced isotonic electrolyte solutions are always safe compared to hypertonic electrolyte solutions or saline of 0.9% strength. That would protect children against risks of hyponatremia or hyperchloremic acidosis. For maintenance infusion, additional 1.2% glucose is sufficient to avoid hypoglycemia, lipolysis or hyperglycemia in children. Now coming to a little elaborate way of talking about the same thing, let me tell you the preferred solutions fluids are lactated ringer solution, lactated ringer solution and plasma-lite A. Normal saline can be used definitely, but as I just mentioned, it can cause hyperchloremic, hypernatremic metabolic acidosis. That's the problem with normal saline if it is given in large quantities. And I'm sure you know about 4-to-1 rule for maintenance therapy. You have to multiply the number of hours the patient or the child has been fasting by 4-to-1 formula. Replace 50% of that deficit in first hour and remaining 50% in the next hour. So that's very, very interesting. I'll tell you how to calculate 4-to-1 formula also. The maintenance rate of pediatric ratio is how you calculate. The children up to 10 kg estimated is 4 ml per kg, requirement. And the next additional 2 ml per kg for each kilogram of body weight between 10 kgs to 20 kgs. And an additional 1 ml per kg for each kilogram of body weight above 20 kgs. And you should always think about additional fluid replacement if there is a third space losses such as evaporative losses. And that's how you have to give fluid replacement depending on the child's blood pressure and urine output. When it comes to urine output, the goal should be minimum 0.5 to 1 ml per kg per hour. Suppose the child has been brought to you for emergency surgery, there could be more loss, third space losses in the form of vomiting, fever, blood loss. So you have to cater for higher amount of fluid deficit. Okay, so you have to think about that also. And if there is a minimal invasive surgery, the estimated requirement of fluid should be around 2 to 4 ml per kg per hour. Moderately invasive surgery requires 40 ml per kg per hour. And if it is maximally invasive, you have to give even to the extent of 8 to 10 ml per kg per hour. To this, you have to add maintenance therapy fluid also. That is, as I just mentioned, 4-to-1 rule. And you can give 1 ml loss blood. If there is 1 ml blood of loss, you have to replace it by 3 ml of isotonic crystalloid. And if there is 1 ml of loss of blood, you can give 1 ml of 5% albumin or blood per se. And if you are giving packed red blood cells, it is the same for 1 millimeter to 1 milliliter. liter. Sorry. But if you are giving replacement crystalloids, you have to give 3:1. That means 3 ml of isotonic crystalloid for each ml of blood lost. Okay. And as I just mentioned, if the child is more than 1 to 2 years, there is always lot of stress, and that itself causes rarely any chances of hypoglycemia. So glucose requirement may not be there. But if the child is less than 1 year, there could be glucose requirement, and that is the time you should preferably give 50% of dextrose in 0.45 normal saline. Okay, intraoperatively. That can be given as piggyback infusion. Thanks for patient listening. I hope I have given little nutshell of fluid and electrolyte therapy for pediatric age group. Have a wonderful day. Bye bye. Take care.